ABC, CBA, XABC, March, RSI versus resuscitation in trauma, all coming up next on the very first episode of the Viral Unpacking Podcast with me, Charlie Swearingen. Let's get to it. Hey everybody, thanks for joining the Viral Unpacking Podcast, where we're going to feature a lot of different people on social media. There'll be some medical stuff because I'm a medical and I'm working on a PhD. There'll be some sports and motivation, determination, and people overcoming odds. As a U.S. volleyball player on the Paralympic volleyball team for 2016, that's a big thing that I love to really watch and look at and to be able to share. I'm a bilateral amputee, so there'll be some stories of that. That's got me into the philanthropy world, where I'm a part of I'm on two different boards for two different charities. So a lot of that will come out. So there'll be a whole mix and hodgepodge, but we're going to start off today with some of my things that I love to do, which is medicine and critical care transport and that kind of thing. Now, I'm not a physician. I'm a flight paramedic, which basically just means I went to paramedic school. I did some extra training for about 2 years so that I can be qualified to work in the critical care environment. And that doesn't mean that I was good at it yet. I had to work to get to that point after getting hired. So it's a long, kind of arduous process, but I love doing it. And so while I'm not a physician, we do look toward physicians to give us guidance, and that's who we're going to look at today and discuss. There is a gentleman by the name of Dr. Dennis Kim, puts out a lot of really good content. I mean, he has a lot of followers here. Let's see, he's 186,000 followers, over 2.7 million likes. Very, very, very impressive gentleman. And he put out a banger of a TikTok here recently that I want to discuss today. So without further ado, let's get into this. The general idea here is, do we resuscitate before we intubate? And this used to be a debate, and it's not so much anymore, but we will still see people like, well, blah, 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 and so let's hear what he has to say. And my goal here is just to commentate and kind of expound. What he's put into, I think, like 2.5 minutes is awesome. And all I'm going to do is help expound that a little bit. And I usually try to keep things really simple. So big complex topics and when I teach, teach it like very simply. He did a good job here. So all I'm going to be doing is really just adding some things, giving examples of what he's talking about, just to help expand it a tiny bit. But he does a fantastic job keeping things very simple. So without further ado, let's take a look.
As a trauma surgeon who's treated tens upon thousands of patients with critical injuries, there's one rookie mistake I've seen made from time to time, which if you can avoid, you'll save a life. For so many years, we've been taught the ABCs, and I've taught the ABCs of the primary survey when it comes to the initial assessment and evaluation of trauma patients. Ever heard of the saying, GCS less than 8, then intubate? But here's the problem. If a trauma patient arrives to you critically injured, hypotensive, and in shock, the number 1, 2, and 3 causes for that shock are bleeding, bleeding, and bleeding. So
facts. Total facts. So he's describing that, like, we were taught ABC for a long time, it's airway, breathing, circulation. And then, of course, a couple iterations of the AHA and ACLS and PALS and those guidelines, maybe it's better that we focus on C and first, right? And that's such a great thing. It's hard to put anything into practice that we haven't been doing for a while. So I remember it was maybe 8 years ago, people were really balking at it, and like you'd watch people practice and they're just doing the ABC versus like, hey, let's focus on CBA a little bit more and really putting it into practice. Now, the whole premise to that, of course, was in cardiac arrest, doing chest compressions builds up slowly. You basically recruit pressure by compressing the heart, and that negative pressure or that positive pressure that's released when you release that chest wall, and that creates a little bit of negative pressure, is pulling blood back to the heart. So you are increasing that pressure. And that's why stopping compressions, it all of a sudden has a dramatic decline. It's the same thing as we're focusing on that cardiac portion, and now we're throwing in another layer on top of it. What if they are bleeding, whether that's bleeding outside or bleeding internally? Any bit of that. And I had a recent call where this is what really resonated for me was a recent call where patients awake and alert, a little bit confused, but complain they can't breathe. I mean, we have air hunger. If we don't have oxygen being delivered to our tissues, we are air hungry, right? Whether that goes into our lungs, goes onto the red blood cell, goes all the way to the tissues and offloads and gets to the mitochondria, but it doesn't do its thing. Anywhere along that path, if oxygen is not delivered to the tissues get air hungry, and that's what this person was experiencing. And so his words really resonated with me. Now, again, ABC, unless they're bleeding, considering that CBA, and there's a bunch of different ones we'll talk about as we go forward. But he's established this point pretty well. He's going to get into focusing on resuscitate before you intubate. Love it. GCS less than 8, intubate. Let's fix that. And somebody in the comments down here actually says that. And it was a guy, this Dr. Jacob Ott, I think. Resuscitate before you intubate. It's the new less than 8 intubate. Love it. I haven't looked you up, sir. Well said and outstanding. Let's keep going.
So if you're prioritizing A before C, you may potentially harm your patient. And here's why.
He's about to tell us, but if you try to intubate and go through the RSI process, which has a lot of gremlins, when I say gremlins, I'm talking about things that will knock down cardiac output. That's usually my teaching points. If we focus on that first before getting them, whether it's fluids, if for the hypotensive, for the hypovolemic patient, blood for the hemorrhagic patient, which is the center point of this conversation, or pressors, or whatever we need to support that blood pressure, because we are about to, if you RSI and intubate, you were going to knock down some of their cardiac output. And cardiac output is an important thing, and it's kind of a enigma to think about. But what we actually best relate cardiac output to in our assessment is blood pressure. They are not the same thing. However, if you have a good cardiac output, there's a good chance you're probably going to have a distal pulse, i.e., a blood pressure. And so those are some of the things that we'll talk about here. But let's see what he says. Let's see what he says specifically about this part.
When patients are in hemorrhagic shock, they're hypovolemic, they have decreased preload, decreased stroke volume, and a decreased cardiac output. All of that translates into a reduced mean arterial pressure. And it's so important to remember the cardiac pulmonary interaction. So if you start administering positive pressure ventilation to a hypovolemic patient, if you increase that intrathoracic pressure, you decrease venous return, preload augmentation, and stroke volume.
So I want to stop it here and really focus on the determinants of stroke volume. And you can see down here that cardiac output equals heart rate times stroke volume. Very important thing. Cardiac output is about 4 to 8 liters per minute of blood that goes around and around in our vasculature. Now, the really cool thing is we have another number at 4 to 8 liters per minute. And blood goes around and around every minute, but we also breathe every few seconds. And so that brings in air. And if you tabulate all that air up, you come up with a number in liters per minute. And that's our minute volume. That is our minute volume. So the air in and out has to match the blood that goes around and around, or we have a shunt. Now, Dr. Kim doesn't mention here like shunts or VQ mismatch or any of that, but that's exactly what he's talking about. And he's basically saying if we are doing positive pressure ventilation, that we when you push air into the chest, into the airways with a bag valve mask, it basically increases the pressure and it smashes all the vasculature a little bit. If you hold if you're trying to get an IV and you occlude proximally, then you're tamponading off the blood flow and the vein engorges so that you can get an IV. In this case, it smashes those vasculature and blood can't return to the right side of the heart. And so if we do too much positive pressure ventilation, we can essentially tamponade off a lot of blood flow. If we're breathing 30 times a minute, all right, which can happen very easily, that's not awesome, but we get all revved up, and there's actually studies out there that show that we bag fast. Even docs, even flight nurses and paramedics and pre-hospital, we bag fast. So let's just say for a second, if somebody bags 30 times a minute, that's 30 times that we cause that tamponade and slow blood flow return back to the heart. If you can drop that by 10 or even 15 to 15 or 20 times a minute, you just reduce the number of times you've caused tamponade, and therefore we have way more blood coming back to the heart. It's little things. PEEP is another thing. If you have a PEEP valve on there, PEEP is great because it helps to oxygenate. We get to about double digits, around 10 or 11 or 12, and the science shows that that's when we really start having increased intrathoracic pressure to the point where maybe we're starting to execute that same problem of too much intrathoracic pressure, therefore reducing venous return. And maybe that on its own doesn't do very much. If we just put somebody on PEEP of like 15 or 20 that has a kind of low blood pressure, it's probably not going to send them into some type of extremis. But when you start adding all these gremlins together, when you start adding all this stuff together, it's like, when you add all these gremlins together, then they really reduce cardiac output. And we note cardiac output, we manifest it, we conceptualize it as a blood pressure. We can assess it as a blood pressure. Cardiac output and blood pressure are not the same thing. However, if you have a good cardiac output, chances are you're going to have a measurable blood pressure. Now, if it's good or not, that's where we have to apply medicines, because the way that we adjust it is simply with medicines that affect and therapies that affect preload, medicines and therapies that affect contractility, and medicines that affect afterload. So with preload, things that we can fix preload is fluids. We can give a fluid bolus. And if it's trauma, we try to minimize, isotonic crystalloid to 1 or 1.5 liters total in like the first hour. Sometimes that's all you have, and we get that. The point, if that's all you have, is to try to figure out how to get them to blood, get blood to come to you, or figure out some pressors. You don't want to give them 3 or 4 liters of fluid. I'll do other videos on that later. However, fluids will increase preload. All right, blood will increase preload. Blood's great because we get isotonic crystalloid in there. As isotonic crystalloid, it's isotonic, so it inherently doesn't move on its own, but it will get plucked out of the vasculature by thirsty cells. And that's why after about 15 or 20 minutes of a fluid bolus, it starts to, wane on down. The blood pressure wanes back on down. It's just because it's the cells are picking the fluid out of the vasculature. So we give blood. If you have whole blood, that's great, because that's whole blood. That has the plasma, which keeps fluid in, it has the red blood cells, which carries the oxygen, it has the platelets, which plugs holes. Okay. If you don't have that, then we could do a 1-to-1-to-1, where we have 1 unit of plasma, 1 unit of red blood cells, 1 unit of platelets. Again, achieves the same thing. It's just a little different because you're going to have some other components in there to help keep them shelf stable. If you don't have 1-to-1-to-1, then you do 1-to-1. You do yellow or plasma, and you do red blood cells. If you don't have that, then you just do packed red blood cells. If you don't have that, then you do your TXA. Right? TXA potentially, if you're giving blood, calcium's a great addition to that, because calcium, you have hypocalcemia with stored blood. If you don't have that, then you go to the fluids and start worrying about pressors. But all of those will improve preload, right? Fluids, including blood, will help directly affect preload. TXA and pressors indirectly improve preload by simply, TXA will help, stop bleeding internally, and the what was the other one? TXA and pressors. It'll make the tube a little smaller, so the pressure goes up, so a little bit more fluid is actually getting back to the heart for preload. It's an indirect action, but it does help. Pressors typically improve change afterload. So if the pressor is pressing, then it increases afterload. So the heart has to overcome that. Vasodilators open the vasculature. It makes it easier for the heart to pump out of. And that's a trade-off. Like if you vasodilate, your blood pressure is going to go down, which is why in a minute we start to talk about RSI. Like a lot of our sedatives do that. They cause a little bit of vasodilation, and we have a drop in cardiac output. Therefore, we have a drop in blood pressure. So again, another gremlin, the positive pressure ventilation gremlin, the PEEP gremlin, and the vasodilation gremlin all can nick away at cardiac output. All right, and then contractility, those are your inotropes. For afterload, we have your dromotropes and your chromotropes and your beta blockers, and so things that rev up, afterload, pressors. Pressors and vasodilators for pressors. And then the thing I didn't mention yet was heart rate. That's our chronotropes and dromotropes, which increase our heart rate. We also have beta blockers, calcium channel blockers, other things that slow heart rate, amongst some other things. But we have complete control over this right here. And then if you add the ventilator component, and we change minute volume, you all of a sudden have an entire picture of air in and out and blood going round and round. We have control over that. We just need to pay attention to it. And what Dr. Kim started with was, if you do this, you can save a life. All right, let's get back and let him talk.
Preload augmentation and stroke volume. A number of reflex compensatory mechanisms kick in when someone loses a significant amount of their effective circulatory volume. The sympathetic nervous system is activated, there's a huge release of endogenous catecholamines, cortisol, epinephrine, ADH, and all of these factors are designed to increase systemic vascular resistance, tighten up vascular tone, hold on to fluids, thereby increasing the MAP that's already down because the cardiac output is low. And typically we'll perform rapid sequence intubation. We rapidly provide anesthesia, sedatives, followed by a paralytic and intubation. This is what's known as sympatholysis. You completely knock off the patient's drive, decreasing their vascular tone, decreasing that sympathetic drive. And if you haven't tanked that patient up prior to putting them on the ventilator, your patients can crump. So
boom, right there. All right, so he brought back that into it. You want to prep your patient. We want to resuscitate before we intubate, because we don't just intubate, but we also put them on the ventilator. And again, on the ventilator, we're going to be giving positive pressure ventilation. It's not just the bag valve mask, but actually on the ventilator. And we're probably going to adjust PEEP. And those two things together are gremlins that knock away cardiac output. And so, and then the intubation process. RSI medicines that we use, the two things typically is, a sedative and a paralytic. Even etomidate, recent literature shows that even etomidate can drop your cortisol level. Cortisol is a very important component of the sympathetic response. Sympathetic response, we have all the catecholamines that are released, causes vasoconstriction, and some of them increase heart rate. Again, fixing cardiac output, heart rate times stroke volume. Stroke volume will increase as a pressor squeezes, and of course the heart rate goes up. That's what epi and a little bit to that effect norepi does. And so once we have the sympathetic response, you also have cortisol, right? And ADH do their thing. Cortisol basically tells the kidneys to not filter as much water because we're trying to keep water. It also hangs on to more sodium and hangs on to more water to make sure that we basically don't just lose the volume that we need to maintain our blood pressure. So even etomidate, which normally is a really, really safe drug, a lot of good literature out there that basically says, okay, if in a hemodynamically compromised patient, you can still have a drop in cardiac output, i.e. a drop in blood pressure, another gremlin, if you give etomidate. So there's the recommendations now. The one we just looked up a second ago on Up to Date was 0.5 to 0.3. So it used to be 0.3. That's what we memorized. Now on the hemodynamically compromised patients, maybe we go half. So look that up, and we'll do probably more videos, because that's the great thing about these videos is I've already written down a couple things I want to. We need to do one on this, and then on this, and then on this. Now, etomidate and for sure the benzos, Versed, Ativan, but Versed's a pretty common one. Versed literally, due to its GABA effects, its receptor, it causes vasodilation. And vasodilation is another gremlin that nicks away at cardiac output. And fentanyl is a great drug. Now, you give it a little bit higher doses, we can have a release of, you get a little bit of they get sleepy, right? It's a pain medicine, but they get a little sleepy. And that's why we use it sometimes in that capacity. In the trauma patient, it's a two bang for your buck drug. Helps to take away a little bit of their pain and also makes them a little sleepy. So when we give, and typically fentanyl is a pretty safe drug hemodynamically, unless you have all these gremlins at work, and then you give fentanyl. Probably the first or second dose isn't going to be the biggest deal, but more and more doses, what you could see is a buildup. Because if you think, we give morphine or some of the other narcotics, or opiates rather, that's the reason why blood pressure drops with those is because of histamine. Histamine is released, vasodilation, big gremlin, blood pressure drops. Fentanyl is usually pretty safe, but it's because it's given in mics. It's 1,000 times more potent, meaning it takes 1,000 times less particles to get the same job done. So the reason why histamine is released, or the reason why histamine causes vasodilation, is so much is released because every time a morphine sits into a opiate receptor, a little bit of histamine's released. Now, you need 1,000 times less particles to achieve the same thing than you with fentanyl than you do with morphine. So the point there is there's just a lot less histamine created with fentanyl. And it's great. And so it's usually good, but it can still drop cardiac output. It definitely can contribute as a little gremlin. And there was another, ketamine. So ketamine, actually the cool thing with ketamine is it acts very, very similarly to benzos. It actually causes vasodilation, but ketamine has a cool side effect that once you give ketamine, it causes a release of endogenous catecholamines, epi, norepi, dopamine, vasopressors, increases vasopressors, and your body like immediately will start vasopressing as well. Or I don't mean to say vasopressing. Will immediately start to press the vessels and counteract the vasodilation. So it's a really, really cool thing. Now that could come into play and really be screwed up if you have been extremis for, I don't know, the longer you're at extremis, the less catecholamines you have. And so somebody who's catecholamine depleted, you give them ketamine, you can actually bottom their pressure out. So the point here is, and to his point, to resuscitate before you intubate, there's a lot of, in just the sedative realm, of little gremlins that could come and reduce cardiac output and therefore reduce blood pressure and cause a problem if you try to intubate before you resuscitate. So I'm all in. The paralytics, once you give a paralytic, the musculature in your, everywhere, all your skeletal muscle, including your intercostal muscles, they relax. And when they relax, you drop a little bit of intrathoracic pressure, and basically you have less blood return coming back to the heart. So because it's a balance. You have a little too much with too much positive pressure ventilation, increased intrathoracic pressure, and then it smashes and causes tamponade. You don't have blood flow back to the heart. But when you relax all that, the negative pressure that's supposed to be in your chest reduces, and therefore you're not when you get a paralytic, and therefore you're not bringing blood back from that capacity as well. So it's all these little gremlins that keep knocking down cardiac output. And resuscitate before you intubate. The call we had very recently where awake and alert patient, MVC, definitely have signs of trauma. And had we not given blood early, there was a moment at which this patient began to crump really fast. And we immediately saw heart rate is bigger than systolic, poor radial pulse, delayed capillary refill. We have blood, we gave it. She turned around pretty quickly, and then she was still confused. We intubated her and did bilateral chest tubes in the field, and then took her to the trauma hospital. Had we done the intubation first, there was a point at which, even in the early stages giving her blood, she started to brady down. We were pushing the blood in, and there was a moment my partner said, she's bradying down. And I mentioned, all right, well, let's get the epi. Let's have that all ready. Vasopressin, potentially we were getting that ready. And then within about 12 seconds, 18 seconds, my partner says, I don't know, patient's improving. And I look over, heart rate is back up to about 120s, which it was before. So we literally just caught her and helped prevent her decline. She needed blood. And she needed pressure and blood. And specifically, the blood was the main component that could fix both issues. So resuscitated her. She was still confused. And then we intubated her. Now, so that's what really rings in my mind with this post, and I really want to share some of these things. So it's amazing. Dr. Kim, he does it in such a great way. And, I get off into these comments too. There's one comment, and I don't know this person, but just, can you do a video without saying that I'm a trauma doc, please? ER nurse here, and the self-promotion is just too, come on, get over that. The reason we tell people what we do, she probably hates my intro to this one if she sees it. The point here is, you want to know who's talking. So, to validate if they're worth listening to. There's nothing wrong with validating your data. That's exactly it. So, and I don't think he definitely didn't I'm a trauma doc, you're going to listen to me. Come on, man. He's been kind. He's also kind in the rest of his videos that I've seen. This was the one, instant follow. Somebody said that here later, immediate follow. And I love that. But before we go down to going through some of the more of the comments. Let's let him finish up. He's about to talk about in the military, and I've had the great privilege for a couple of years of training some of the SEAL teams and high performing operator teams, and I've learned a lot from them just being an educator in some of their training. One of the things is March. All right, so M for massive hemorrhage, A for airway, R for respiratory or respirations, C for circulation, and then H for head injury / hypothermia, right? And hyperthermia as well, but it's head / so we make sure we're looking for head problems so we can fix those, and then of course preventing hypothermia, which is the big part of the trauma triad, or the acidosis, coagulopathy, hypothermia triad there. So let's let him finish talking about this, and then we'll jump back off in these comments.
Protocols, and again, the military has really led the way on this, and of course the civilian sector is a little bit slower to adapt and adopt, but the March protocol: address and find and manage massive hemorrhage prior to dealing with the airway, respiration, circulation, head injury, hypothermia. And this study by friend and incredible trauma surgeon and researcher clinician Dr. Paolo Ferrata and the AAST has shown that using a CAB approach is actually quite commonplace these days and not associated with increased mortality. Key take-home points: address circulation. There's usually never a rush to intubate patients who are coming in as traumas. Like and follow for more.
Yeah.
As a trauma surgeon.
Yeah. So, but what we do have to do is you have to be quick on the moment you don't have to wait. The moment you realize they need blood or blood products and you have them, give them, right? An easy thing, if their heart rate is bigger than their systolic blood pressure, if they have delayed capillary refill and trauma. I mean, you can argue, we could talk about like what they might have, what they might not have. Start giving the blood, then work the problem. You want to get them resuscitated, and then see if you need to do airway, breathing, circulation beyond that. So fantastic. All right, let's look at some of these comments. Some of these are fun. All right, a lot of these talk about this. This person says EMS were taught CAB. That's awesome. He gives a good kudos. CAB for cardiac arrest, XABC for hemorrhage, and that's a good way to do it. I've seen we see this a bunch through here. For medical, they do XABC, ABC for medical, CAB for cardiac arrest, XABC for hemorrhage, and look this stuff up, guys. Make sure you look to see if this matches, if it makes sense, if it matches some of your protocols. Maybe you guys can change some of your protocols if you see something you really like that's different. But these are all solid things. This person, that's kind, very kind words, and he's humble. That's very kind. He doesn't beat his chest up. I mean, I don't know the guy, but it seems like he comes across pretty well. Don't have to use a paralytic, just airway management, sedation. True that you don't always have to do a paralytic, but if you're in the field in pre-hospital, I mean, there's an easy debate that we can, and I've done a couple videos on this. If you're going to put yourself in the position to get your best first pass success, yeah, you don't have to intubate, but if you don't have to use paralytics, but if you don't, and all this muscle is tight and rigid, and you don't very, very well sedate them, then your first pass is at risk. First pass success is at risk. So, this is medicine. We have to look at the patient in front of us right now and figure out the best things to do for that patient right now. And we can't make a video for every patient. So, he's right here, and I think Dr. Kim makes a comment, then it wouldn't be RSI. And that's true, right? That's just drug assisted. Yeah, well said. Brilliant doctors. If someone isn't breathing unconscious, has an unprotected airway. This person uses etomidate, intubate, and transfuse, both important to address. Yep, I mean, still, you before I start worrying about all my airway stuff, I'm going to toss somebody the blood, say, please hang this, or toss my partner, let's get this going right now. And then I give it to somebody to hang or to push through the blood set. In the UK, they're using CAB, CABCDE. Nice. With C standing for catastrophic hemorrhage up front. Nice. This happens. Yeah. The idea of change, military, that's the the last 20 years of military combat has given us ridiculous amounts of information, from the research of how to use blood, what the best ways, some of the best recipes, and the fact that they need it early, and just beautiful. So, right now we're carrying whole blood as part of a big study. There's other areas on the ground. Now that's in the air. There's a lot of air services now carry blood, like raw, regular blood products right there that they can take to the patient. 15 years ago when I first started, I did a short little survey-based study where I wanted to know the blood availability, and that abstract was posted or presented at AMTC, and what we looked at was only about 30%, 31 I think percent of the flight programs at the time had access to raw blood product that they could take to the patient. Everybody could use it if they had it, but only now it's way more. Now it's a study that we're about to do now to do an update. Most flight programs carry it now. Is a fair, I think it's a fair thing to say from my anecdotal experience working with a bunch of different groups. Ground services, some carry it. And honestly, it's not as hard as you would think. So if you don't carry, you don't think it's not a thing, I would encourage you, if it's something that you believe in, go track down the how and the needs that need to be met to make it happen. It can happen. Other ground services are doing it, and if you don't, you do the best you can, right? Let's see, nursing student. Yeah, so a lot of folks are talking about TNCC, which is the nursing trauma course, which is awesome. I've taken that a couple times. Here's an anesthesiologist, hemorrhagic shock femoral vascular. So this guy he would have died had they not corrected his vascular issue before they got him intubated. Bunch of paramedic schools here, and I mentioned a couple that I did like. Anyway, this is all, yeah, he presents it very well. And again, ex-ABC. I mean, this was just overall a very, very, I love this. Can't start the car if you don't have gas in the tank. Yeah, I did like that a lot. So ultimately, overall, resuscitate before you intubate. And that means like the moment that you detect a shocky patient in the face of trauma, blood. Now, again, make sure, I mean, like, if there's ever a doubt, you're not going to hurt them by giving them blood, most likely. But do the things that you need to do to prop up their hemodynamics. That's what we've been talking about. Prop up that cardiac output. Get a good blood pressure as you can. Get a radial pulse. Get capillary refill less than 2 seconds. Try to get your heart rate under your systolic blood pressure. Right? That's the shock index, and I could care less to remember what the numbers are. Honestly, it's 0.5 to 0.7 of a shock index, where you take the heart rate divided by your systolic blood pressure. If it's 0.5 to 0.7 is normal, 0.9 or above is shocky, or has a shock index indicating that shock is present. That's a lot of numbers. Or you could just say, if the heart rate is bigger than my systolic, that's an indicator of shock. Do they have delayed capillary refill? Yep, that's pretty slow. Did he feel a radial pulse? Yeah, but it's real weak. What are we talking about? Go ahead and give the blood products if you have it. Or if you don't have it, then you give your fluid bolus. Then you start working on your pressor. We didn't really talk about the depth of pressors. I don't want to get too deep into it. Vasopressin is a great drug in trauma because it not only causes vasoconstriction, but that big vasopressin molecule recruits water in. So it gives itself its own fluid bolus from plasma. It basically brings into fluid into the vasculature because that molecule is so big, water and fluid wants to hang out with it. So it gives its own fluid bolus to itself, and it causes vasoconstriction. So with that, I hope you enjoyed it. Look, this podcast, we're going to cover a bunch of different topics, and there will be playlists where, there's the medical playlist. This is the philanthropy playlist, the stuff that has to do with amputees or disabled folks that, like, again, I'm a bilateral amputee. There'll be some volleyball and, sport stuff. So there'll be those playlists, but this is one of my favorite things to discuss. It's what I love to teach. So I hope you guys enjoyed it. Thanks again. And please come back and join and watch us on the Viral Unpacking podcast. Don't forget to leave a like, subscribe, follow for more. See you guys.